Mr. Asad Qayyum.
How are you? Good afternoon.
I'm very well, thank you. Thank you so much for coming on. I know we've been trying to get you on for a while now, but it's finally happened. So thank you so much for your time. So ENT obviously is your bag.
That is correct.
So I want to talk all things ENT, and I'm going straight to the point because I think one of the biggest topics is around sleep apnea. So if you talk a bit about starting off, what is sleep apnea?
So sleep apnea is basically where individuals stop breathing during their sleep, and that leads to a drop in the oxygen levels. Essentially, then the individual wakes up to gasp for air, and because of this cycle being repeating itself multiple times over the course of the night, the individual who is suffering from this condition does not have restful sleep, and as a consequence of that, they can be quite tired during the course of the day.
Okay. And what kind of things, there's various things about saying dangerous, probably not the right word, but why is it important to consider as a diagnosis in terms of how it affects the person's health?
So it can have multiple effects on an individual's health. Physiologically, it can affect the heart, and individuals can lead to heart failure. Or otherwise, on a day-to-day basis, the patients can suffer with an increased sleepiness, which can affect their performance at work. It can affect their driving. It can affect their mental cognitive functions. They can become quite restless and irritable. The concentration span gets affected. And the worst one out of all of these is that if they are married or they have partners, the partners get affected and their sleep gets very disturbed.
It's often the partners actually find out about this because the main symptom is generally, people say snoring, but it's an apneic episode can be different to snoring, but the partners pick up on this most often. Is that correct? And what's the difference between snoring and an apneic episode in terms of what the partner might see?
So snoring is quite common. Adults snore, children snore. It's not a problem. But at the end of a prolonged snoring episode, suddenly there's a period where there's a respiratory pause, and the patient is not breathing and is completely silent. And this can be a couple of seconds to 5 to 10 seconds. And that is essentially a sign of apnea or sleep apnea. And at the end of that pause, the person then sort of resumes the breathing with a bit of a loud noise and a bit of a grunt, and sometimes may even wake up a little bit as well.
I see. We'll talk a bit about it affecting the person's performance, but one big thing is around weight. Now, can you talk about sleep apnea and weight in terms of being overweight? Because I know there's a bit of a cycle there about sleep apnea being a cause of weight gain. Therefore, it's almost impossible for someone with sleep apnea to lose weight. So it's kind of like, what came first? Is it the person was obese thing or sleep apnea, or did they get sleep apnea which caused the obesity?
So before we talk about that, let me just divide it a little bit more. Sleep apnea can be central, which means there's a problem with the mechanism of respiratory drive from the brain at the time when the individual is asleep. And sleep apnea can be peripheral, which means there is obstruction at the peripheral organs, so mouth and nose, etc. Central sleep apnea is a completely different cup of tea. And central sleep apnea is not very common. But peripheral sleep apnea, which is what commonly is considered to be sleep apnea amongst masses, is quite common. Now, coming to your question about what comes first, essentially, a lot of these individuals will probably be a snorer for a long period of time. And due to the anatomy or the shape of the way their mouth is or their nose is, a little bit of weight gain increases the resistance of the flow of air from the mouth or the nose to the lungs, and that leads to an element of cessation of breathing at night when they're asleep, and that is classified as sleep apnea.
Okay, so the weight gain can be muscle as well as just being someone that's for example, bodybuilders potentially.
So it's body mass index which increases. So I would always look at the body mass index. It's not just simply obese or fat. Patients can have, I've had patients I've treated who've been bodybuilders and they've got quite a big neck. and quite a big shoulder buildup and very muscular neck. And at night when there is sleep and the muscles lose their tone when an individual falls asleep, that leads to collapse of the muscles becoming relaxed, pressing on the inside of the oropharynx, mouth, back of the throat, and the passages for breathing, leads to blockage and choking at that level.
And what so with sleep apnea, what are the other causes? You mentioned obviously, a big neck essentially, whether it's muscle or being, obese. What other factors what are the risk factors of sleep apnea?
So basically, if an individual who's well in themselves and suddenly starts to gain weight, we first need to make sure that we exclude other causes. So, for example, make sure they're not diabetic. Exclude if they have got a compromised or a low thyroid function, because a lot of individuals' diagnosis of hypothyroidism actually comes to light when they start to gain weight. So we need to do these blood tests to exclude that none of this is happening. Once we've excluded, then we review the patient and assess them. And then look at, first thing is the weight, and then talk to them if they're suffering from disturbed sleep. Ideally would like to see them with their partners. We'll mention about snoring and respiratory pauses at night. We ask them if they are becoming irritable during the course of the day. We also ask them if their concentration is not as well. We also inquire if they are tired during the course of the day. They don't have the motivation to do anything. They want to go to the gym, they want to exercise, but they just can't find the get up and go to do the exercises and to go to the gym. And that puts them into a negative trajectory, leading to further sort of couch potato habits, further gain weight, and obviously depression, mood swings, headaches, all of these factors together. The other thing is, for men, particularly low testosterone levels can also lead to weight gain. And low testosterone levels is almost as common as 1 in 4 men may have it without realizing that they have got low testosterone levels.
So is that because with sleep apnea, it obviously you're sleeping less, you're getting almost no good quality of sleep. Therefore, does that, my understanding is that raises cortisol level, is that correct? Chronically?
Yeah.
And is that what leads to all these other conditions?
Yeah, so because the cortisol levels go up, the weight gain goes hand in hand with it. It also makes them more prone to diabetes. So all of these, lack of sleep actually has a negative effect and leads to an increase in all these hormones, which then have an effect which is not what the patient wants and leads to weight gain.
So with all these comorbidities, I mean, sleep apnea is obviously a major health, it needs more health awareness. And I think recently, especially in the UK, it's been on the sort of the disability list. So patients who are diagnosed with sleep apnea now can claim kind of money for not being able to work. So because of that, I've seen a lot of influx in primary care. The issue I've seen is that a lot of patients may have sleep apnea by being kind of not offered a referral because what's being used is the Epworth Sleepiness Scale, which from my understanding is not meant to be a screening tool. Is that kind of how you'd expect as a consultant not to it to be used as a, if you don't meet a certain score, you shouldn't be referred for assessment?
So Epworth Sleepiness Score alone is of no importance. It should be used in conjunction with a few other assessments, such as one thing is Stop Bang Score, plus the history of the patient, plus the anatomical appearance of the mouth, the back of the throat, i.e. the height, the size of the palate, the uvula, which is the dangly bit in the throat, the bulkiness of the tonsils, the height of the base of the tongue, plus looking inside the nose if the individual has got the septum, the partition between the nostrils is deflected and leading to nasal blockage or nasal polyp. So it's a combination of all these things together, plus as well as the position of the jaw. Some people have a jaw which is set further back, leading to more congestion of the back of the throat, again, putting them at a high risk of sleep apnea. So when we assess these findings along with the sleepiness score, then gives an idea whether an individual is actually suffering from sleep apnea or not suffering from sleep apnea.
So essentially what you're saying is the patient should ideally present to a GP either from their partner and said, look, you're having these apneic episodes, or they're feeling tired all the time. They should come to the GP, who should theoretically, yes, do a sleepiness scale, but also do all the blood tests examine them, then refer on to you guys, ENT, and then is there a definitive diagnosis for? Is there a test you can do to diagnose people with sleep apnea definitively?
Yes, so there is a test called the sleep study, and we can do that to definitively diagnose if the individual is suffering from sleep apnea. Now, that test can be performed in various hospitals. However, the test is now available online as well. So patients can, I'm not going to take any names, but if they search, they'll be able to find it. There are various companies who will send individuals a sleep monitor that they can attach and get the results and post it back to them, and they will post the results back out to the patient to confirm or exclude diagnosis of sleep apnea.
And are they as good or as accurate as
They're reasonably accurate. They are fairly accurate because the results are studied by either an anesthetist or a respiratory physician. So they're not studied by the machine printout simply. So there's a specialist who studies and then signs their name at the bottom of the result.
And essentially with that, it will show basically episodes of your sats dropping. That's what he's looking for, right?
Correct. You're looking at the episodes of desaturation or saturations dropping below 90%. But what's more important is the frequency as to how often are they dropping over a 7 or 8 hour period of sleep, plus how low do the oxygen levels go. It's a combination of all those things that matter.
I see. It just interested me, because with sleep apnea, there are all these things you mentioned, like diabetes, weight gain, low testosterone. What kind of things do you see in every day? Like with people who, like, say, have had a long-term sleep apnea without maybe knowing it, and they come to you, what kind of things do they experience? Do they have like you said, mental health problems, but does it even affect like their skin quality? Does it affect it almost across the board?
It's
right?
usually the partner who sends them across. It's the problem to the marital bed where the partner is sleeping in a separate room. That is what initiates the first visit. Plus, if they find themselves at times falling asleep at work, and somebody from the work will say, look, I think you better need to see a doctor.
And how do you treat it? I know obviously there's CPAP, probably everyone's heard, but yeah, if you talk a bit about what that is and what the other options are out there.
The options for treatment are, for peripheral sleep apnea, the options for treatment are, if you've got moderate to severe sleep apnea, the treatment is a CPAP machine, which is a small device. Now, actually, it's very small and it's pretty silent. 10, 15 years ago, they were quite bulky and pretty noisy. Now, these devices are fairly small, and an individual can stick them, wear them around their nose or their mouth, and they sleep with it. And basically, it's got a sensor inside it. And every time the resistance in the upper sort of aerodigestive tract drops, the machine exerts a pressure which keeps the airway open and also gives them, so that helps in patients having a very refreshing sleep. But for patients who are simple snorers and for individuals who have mild sleep apnea, they can be treated surgically. And surgery is done by an ENT specialist. And surgery involves, if the nose is blocked, we can do an operation to widen the nasal cavity or the nasal passage to help improve the breathing and establish the normal anatomical pathway or passage for breathing. If the individuals have very bulky tonsils, they can be reduced in size, or tonsillectomy can be performed. The uvula, the dangly bit in the center of the throat, that can be shrinked. And also the palate, which can be quite floppy and fluttering as the individual breathes, various measures can be taken to tighten them up, tighten the palate up, or make it stronger to reduce the chances of snoring. Now, along with that, some individuals will have a very short set mandible or the lower jaw, and these individuals will be advised to see their dentist, or there are what we call mandibular advancement devices which are available online, which the individual has to wear at night when they sleep, and it stops the jaw, the lower jaw, from collapsing back, leading to obstruction in the upper aerodigestive tract, which leads to snoring. And latest is a little, which is not in this part of the world easily available, definitely not on the NHS, is presence of a small sensor kind of a thing, which can be applied in the back of the tongue, where the moment the tongue starts to lose its tone, the machine has sensors. They fire away and increase the tone in the tongue, which basically keeps the back of the throat and oropharynx open. But again, I always tell my patients, snoring is one condition where one size does not fit all. So treatment has to be tailored to your specific needs. And irrespective of whatever treatment we do, we can never convert somebody who's a snorer into a silent sleeper. It gets better, but it will not become completely silent.
So I'll touch on that snoring point in a second. It's just going back to the treatments. I've seen a lot of neuromuscular retraining devices, in particular, stating they can help with sleep apnea. Some of them do have good preliminary data behind them. It's interesting about the device you mentioned about the you put at the back of the tongue. That sounds quite interesting, actually. But do you have any experience, or is there anyone that's asked you potentially about using a neuromuscular retraining device? So normally they come in, like, you may have seen them, like there's something you put in the mouth and it is around exercising, basically. Is there anything?
The evidence around those is pretty weak. And majority of the papers for a few of the devices that I've seen are actually sort of written by the people who promote the devices. So I'm not sure about the validity of those papers. There are some neuromuscular modulators which are applied, where you can put a little sort of a sensor in the base of the tongue, or the muscles of the base of the tongue, or under the tongue, where every time the tongue starts to lose its tone, they fire up and make the tongue tight, so that the individual is able to breathe. Avoid sleep apnea. The problem with this is that these have to be surgically placed inside you, or inserted into the patient. And the second side of it is that the results are they're very expensive. They're not available on the NHS, they're available on the private sector. But again, the experience of people doing it is very far and few.
So essentially you're saying the mainstay. So going back to that, it's interesting you mentioned about the device at the back of the tongue. Have you had experience with that? Obviously not on the NHS, but anyone?
Personally, I haven't. No.
It sounds quite interesting though. I mean,
yes, it is, but it's personally I haven't. It's being used in the US, but still sort of in the UK, we are still quite conservative. And we would only use something which is either accredited by NICE, or which is a National Institute of Clinical Excellence, or there are some data available which is backed by good quality of evidence. Only then we are in the UK advise these treatments to the patient.
I see. Whereas in America, it's a bit of a different system. So anything that's, I guess they can use it. Their threshold for advising them is probably a bit lower than.
That's correct.
Because you have to go through NICE and then go through local guidelines and local prescribers. It's a long process. It's got its pros and cons. But, that's the way it is. But go back to the snoring thing where you mentioned about you can never essentially cure it. So there's no cure for snoring.
Well, you can cure it to the point that somebody whose snoring is, say, 8 or 10 on a score of 1 to 10, they will get down to 1 or 2. And majority of my patients will come in and say, I actually had to wake up and make sure he's not dead.
Oh, really?
So they become very quiet compared to where they were. And the partners are always very happy that it's gone from being unbearable and separating the bedrooms and the marital bed. They're now actually back into the same room.
And that treatment for that is either, like you mentioned, whatever the cause is, because it depends widely if it's an anatomical problem. And what are your thoughts on the nose taping that a lot of people are doing, not even if they don't snore, they're just doing it to improve, So
nose taping is helpful. I would advise as well. And nose taping is specific to the individuals who have a collapse of the nostril at this level because of the weak alar cartilages. But nose taping is not helpful for every single individual.
Is there anything else people can do at home? Say they're snoring, and the waiting list to see an ENT is 2 years in some parts of the UK. Is there apart from nose taping? Is there anything else out there you think people can maybe buy or try, or any exercises?
So there are various treatments available. As I said, one size doesn't fit all. The treatment has to be tailored to the patient's needs. So one of those is putting little sort of dilators inside the nostril to keep it open. The other one is to use a mandibular advancement device to hold the tongue forward so that it doesn't collapse. And some people would say just, stick a little tennis ball to your back so that you don't lie down on your back, or even if you lie down, you turn over, which means that changing position at night is helpful. But again, there is no simple one-step treatment. which is helpful for snoring and mild sleep apnea patients.
So I guess you could class major snorers as mouth breathers, right? So, and what's your thoughts on people who mouth breathe as opposed to nose breathing? Because I think a lot, especially on social media, a lot of people are advocating sort of mouth taping. I think famous footballers have done it. So it's kind of deemed, if you're, nose breathing is better than being a mouth breather.
See, predominantly, why is it that you're breathing from your mouth? The reason you're breathing from your mouth is that you have developed a habit over the years that mouth breathing is better than nose breathing for yourself, which means there is some element of blockage within the nose. Now, it can be a structural blockage because of the deviation of the nasal septum, which is a partition between the nostril, or the collapse of the nasal rims or alar margins, which is the flare of the nostrils, or presence of polyps inside the nose, or an enlarged adenoidal tissue, which is sort of tonsillar tissue at the back of the nose. So if there is any of these areas which are giving rise to structural problems, then the patient will naturally breathe from the mouth rather than the nose, because the nose is not providing them with enough airflow or enough oxygen to support them. And at that stage, if you tape I call it chin taping. And what you do is, like the headband that you wear when you're playing a game of tennis or squash, put that headband around your chin, over your head, and it just holds your mouth shut. But for individuals who are not able to breathe from their mouth, then it becomes very difficult for them to cope with it. Some may say that they have problems which are not present all year round, but seasonal. So they can have hay fever or allergic rhinitis, which can give rise to temporary nasal blockage. So all these things contribute to a habit of sleeping or breathing from the mouth.
So essentially what you're saying, someone could end up almost suffocating themselves if they, if they've got if they develop like a mechanism to breathe through the mouth because their nose is blocking their mouth tape, they're not going to be able to breathe essentially. So your mouth taping is obviously no until you get an assessment, essentially see what the blockages are, right? If there's no blockages, then maybe you can try it. But I think doing it without an assessment sounds like it might be quite dangerous.
Doing it without an assessment is not helpful. Usually these patients in the middle of the night will pull the tape off or take the strap away and just go to bed and say, I can't do it.
Because they need to breathe.
They need to breathe, exactly.
Yeah. And one of the causes, I guess, of all this can be a nasal polyp, right? So nasal polyps can cause sleep apnea, they can cause snoring, So
Absolutely.
can you talk about what is a nasal polyp? Like, and do they all need to be treated?
Nasal polyps are, in the simplistic terms, these are the lining within the nasal sinuses. And the sinuses are essentially present above the eyebrows, between the eyes and the nose, and below the eyes because they give us the prominence of the cheek. And the lining of the sinuses starts to, because we are standing on our 2 feet as mammals, the only mammals, the lining, because of gravity, starts to prolapse out and hang inside the nasal cavity like a bunch of grapes, leading to nasal obstruction.
And is there anything, is this an operation essentially? Is there anything we can do? And there's medication as well to help shrink them, right?
So the first thing is we need to identify if the nasal polyps are because of allergies or they are non-allergic in nature. So if they're allergic in nature, the primary thing is to control their allergies. If they're non-allergic in nature, which means the patient doesn't suffer from hay fever or anything like that, and we do an allergy test which is negative, then these polyps are non-allergic. And then obviously, whether they're allergic or non-allergic, we can treat both of them with a short course of oral steroids and topical nasal steroids, which are available over the counter at majority of the big supermarkets and pharmacies. If the polyps fail to respond to topical steroid treatment by topical amine nasal sprays and to oral steroid, then the next step is surgery to remove the polyps from the nose and sinuses.
And how, because obviously steroids long term can have, obviously, even nasal steroids, relatively weak ones, if you use them for long enough, can have.
So the nasal steroids, there are some nasal steroids which are available, and I'm going to use their chemical name, not the brand name. For example, fluticasone and mometazone. These do not get absorbed in the bloodstream. There are papers published which say that the chances, I won't say completely zero, but the chances of these getting absorbed in the bloodstream is very, very low, even over a long period of time. And hence, as ENT surgeons, we are happy to recommend them to be used for a long period of time. Compared to nasal steroid drops, their absorption is very high.
What about the risk of a nasal septum perforation from, long-term steroids? Is that rare? Is that, something that can happen?
It's rare. Nasal bleeding is common, but septal perforation is not common. And the way to use the nasal steroids is that I tell the patients that the nozzle of the steroid, which is always like the point shape of a tip, put it in the nostril and point it towards the outer corner of your eye. And by doing that, so you put it in the nostril, stretch your nostril, and point it to the outer corner of the eye. By doing that, what's happening is that you are avoiding the spray from rubbing against the nasal septum, because it is the thinning of the lining of the septum which gives rise to nosebleeds.
Interesting, because a lot of people normally just get the thing, the end point upwards, right up towards their forehead.
See, people think the nose goes that way. Actually, the nose goes that way towards the ear.
And how long would you say someone tries on steroids, nasal steroids, before they consider an operation?
About 8 weeks.
Okay, that's not a massive amount.
No.
Not like 6 months or anything. 8 weeks. Okay, that seems reasonable. Okay, I'll move on to slightly another system in ENT, and it's ears, and probably the biggest one you see as well, that I see, and that's probably one of the most difficult one, not just in ENT, probably medicine, is around tinnitus. I kind of started saying like, what is like? Everyone knows what tinnitus is. Well, most people know what tinnitus is, but can you explain a bit about how tinnitus happens and why it happens?
So there is a confusion about what is tinnitus, and people think tinnitus is only a loud noise in the ear. Tinnitus can vary from a loud shrieking noise to a humming noise to a whistling noise to a pulsating noise. Any form of a noise which is internally produced in the ears without an external stimulus is tinnitus. And almost every individual would have experienced tinnitus at some stage. It all depends how quiet the surrounding room or the surrounding area where you're sitting is. If it's absolutely quiet, like you and I are wearing a headphone, I'm sure if I keep quiet and if you're quiet, you'll be able to hear a very gentle humming noise in your ears as well. Tinnitus becomes a problem when it is intrusive, which means the person becomes aware of the tinnitus constantly, and they become focused on the tinnitus, and they start to concentrate on the tinnitus rather than what's going around them. And that tinnitus, which is intrusive, then stops them from particularly sleeping at night and concentrating at work. And that's when tinnitus becomes problematic.
Why do these people hear the tinnitus louder? Is it something to do with the frequency that the ear picks up? That is a dysregulation with the ear shouldn't be picking up essentially is picking up. Is that correct? So
basically, what happens in tinnitus is it's not in everyone, but the commonest form in tinnitus is that patients have got hearing loss. So it's always advisable to have a hearing test done, because in the frequencies where the patient has developed a hearing loss, those frequencies are the one where the tinnitus develop. And I usually explain to my patients that this is phantom noise. So if you ever speak to somebody who's lost an arm or a leg, they'll tell you that I can sometimes I can feel my leg itching, or I want to scratch my arm, but it's not there. That's because the peripheral organ has been taken away, but the central connections are still present. And if there is no peripheral stimulation, from time to time, the central connections fire away. The same happens in tinnitus. When there is hearing loss in a particular frequency, the brain is not getting, the hearing loss is in the cochlea, which is the organ of hearing inside the ear. But the central connections in the brain are still present. And when there is not getting any peripheral stimulation, it starts to produce sort of a phantom noise, which the mind is able to perceive or hear from time to time. And it's usually anxiety, stress, ill health, lack of sleep, which makes, and low mood and depression, which makes tinnitus feel a lot more louder than any other common population.
So what you're saying, if there's no peripheral stimulus, so like no loud noise
Yes.
in people who have got low hearing or a little bit deaf, the brain perceives, is it saying the frequency isn't, it sends a firing stimulus basically, even when it shouldn't do. Is that what you're saying?
That's correct.
And that comes out as a noise.
That's correct.
So what about in patients who've got no hearing loss? Say if they've got no hearing loss, but they still have tinnitus, is that?
That's what I was about to say. That's quite common. Second most common cause, but in these individuals, we are not able to identify exactly why patients get tinnitus. There are some theories there which say that tinnitus is produced because of the movement of the outer hair cells in the cochlea. But again, this is not fully proven.
So, because those are the patients, I think, because with if it's hearing loss, essentially you can almost mitigate that by giving almost like a hearing aid, right?
Correct.
But with the patients that are difficult are the ones that have got normal hearing, but have these tinnitus that really, it can actually really destroy their life, affects everything, right? They can't work, they can't sleep, causes depression, it causes anxiety, that makes the tinnitus worse, and it goes round and round. So they're the patients I think really suffer. But so is there anything that helps or that they can do? Operation or no operation, or supplements or no supplements?
So surgery is not the way forward for tinnitus at all. The only time surgery is indicated if the patient comes to us and says that they can hear a noise in the ear. Usually it's a clicking noise, and it's not classified as tinnitus. And the only time it is not classified as tinnitus is if you tell the patient that it's a clicking noise and you ask them, can somebody hold their ear close to your ear and hear the noise? And if the patient's attendants say yes, then that is not tinnitus, because there is a stimulus that can be heard. And that is essentially fasciculation of the eardrum, or the muscle inside the ear, which is giving rise to what we call as myoclonus. So that's not classified as tinnitus, and that's treated with surgery. But it is very rare for that to happen. But otherwise, tinnitus is very common. And the first thing I tell the patients is to help them reestablish their sleep. And what I advise the patients is to either have a little sort of a noise generator, or now there are apps available on the mobile phone where patients can generate a sound which is close to the level of the tinnitus, which is sort of a white noise, which muffles the tinnitus, and that helps them fall asleep. I normally tell my patients, get yourself a small, the water fountain that you can have in a bedroom from one of the big stores. Put it in the bedroom, switch the water fountain on, and the sound of the water itself is calming to the nerves, and the sound of the water fountain actually, basically, it distracts, or it sort of doesn't allow the patient to focus on the tinnitus. So brain has got some alternative source on which it can focus, and that's how the tinnitus itself can be masked, and the patient can sleep well.
I was actually looking at the NICE guidelines recently. There's something about neuromodulation, about that potentially being a benefit, especially in patients like who don't have hearing loss. What are your thoughts on that? Is that a thing you've tried and you've seen work, or is it still fairly new?
So neuromodulation is new compared to other treatment, but the indication for neuromodulation is essentially, first of all, we have to ensure that all the medical causes of tinnitus are excluded. So you want to make sure the patient doesn't have low thyroid function levels. They don't have low hemoglobin levels. They don't have low iron levels. They don't have any cardiovascular problems. There are no neurological problems. There is no clinical history of clinical depression or anxiety or stress. And then you have fully given the patient the trial of what is known as tinnitus retraining therapy. In other words, it's a type of a behavioral therapy. And once all of these aspects have been tried, only then the patient needs to be referred across for neuromodulation treatment. And to be honest with you, in the last 5 years, I haven't sent a single patient. And I see tinnitus patients in every single clinic that I run, and I'm in the clinic 6 times a week. So it's very rare to do that. In neuromodulation, what we do is, again, you put some sensors or probe in some other muscles, usually in the tongue or in the neck, and they stimulate those alternative muscles. And basically stimulation of the alternative spots leads to some degree of neuromodulation or change in the neural pathway, which distracts the individual from there or takes the focus away from the tinnitus.
I see. So, yeah, it's true. I think recently there was I think Chris Martin, the Coldplay singer, had tinnitus, and he mentioned about Ginko Biloba. I know he stated it helped him. What are your thoughts on that as a supplement to take?
So Ginko Biloba has been around for 50 years, maybe more. It's a herb which is quite common in the Southern Hemisphere, America, subcontinent, and it's been used in those countries for a very, very long time. However, the evidence that Ginko Biloba works is very poor. Cochrane did a review on it in 2014 and found it was not beneficial. In 2017, there was a double-blinded trial done, which was not beneficial. 2018, they did a trial on 1,000 patients and found it was not beneficial, or in other words, very, very marginally beneficial. So a very small group of patients said that they had some improvement. And the fact that Ginko Biloba, some people say, is helpful, clearly suggests the element of placebo effect of a medication.
Which is obviously very powerful, especially something like tinnitus. You know, if someone feels like, you know, whatever the cause of tinnitus is, if they feel like whatever they're doing is going to help them, especially in tinnitus, you know,
I would say do it. As long as it does not have any side effects and it's helping you with the tinnitus, I would say go for it. Don't stop it.
Have you seen an increase in the number of tinnitus patients and sleep apnea, or I guess, you know, all these conditions since the pandemic, since COVID? Because obviously one of the big things we see, one of the big things that everyone knows about is loss of taste and smell, again, which is an ENT obviously system, right? What's been the impact of that now? So we're maybe in 2024 now, so we're 2-3 years out of the pandemic now. You know, is this still a big issue that you see?
So snoring was a big issue. Bordering onto sleep apnea has been an issue, because particularly in the first couple of years after pandemic, because people gained weight. They were not going out. All they were doing was sitting at home and eating. So there was a weight gain. So there was an increase in the referrals for snoring and sleep apnea. So that has sort of plateaued off. With reference to the tinnitus, there hasn't been a drastic increase in tinnitus per se, but there has been an increase in patients who presented to us with sudden hearing loss and patients who presented to us with dizziness or balance-related problems. There has been an increase in that. But per se, tinnitus, I haven't seen any drastic spike in tinnitus patients. As much as I've seen with hearing loss, loss of sense of smell, loss of taste, and balance.
And all those problems you mentioned, so and we know that the COVID infection caused that. But I guess you obviously know more about the long-term effects of that. So patient obviously still suffering many years on with loss of taste, loss of smell, hearing loss, balance problems. Do we know why some people got that and some didn't? Was it a vaccine thing? Was it a thing where did they have comorbidities that may have made them more susceptible to these things if they got the infection?
So I think this element of health has come to surface a lot more since COVID. But we have been aware of patients suffering with loss of sense of smell, loss of taste, hearing loss, balance, even well before COVID. For years, they are diagnosed, they are conditions which are well documented in the literature. But interestingly, all of them have an origin to a viral etiology, which means some form of a viral infection leads to these symptoms. And COVID, being a virus, has actually exacerbated these symptoms. So in other words, COVID's effect on these organs has been very much in line like with any other viral. However, it had a propensity towards the nasal lining and the organs for the sense of smell for a variety of reasons. But we are well aware that variety of viruses can give rise to these conditions.
Is anything, so loss of taste and smell in particular, is anything that can be done? You know, if say someone's had COVID, they've got, I guess we call it long COVID, right? So, and one of the symptoms they've got a loss of taste or smell or hearing loss is probably a bigger one. What can be done?
So it all depends, when do they present to us? If the patients present to the specialist within the first few weeks, and by few I mean to say under 4 weeks, ideally 2 weeks, there is a lot we can help out with. So for example, with hearing loss, we'd give them a trial of oral steroid along with steroid injection in the ear or through the tympanic membrane, so the steroids get absorbed into the inner ear. And majority of these patients actually show a positive recovery, and there's an improvement of hearing thresholds. There is reduction of tinnitus, and if they have basically. On the other hand, with sense of smell, if they present to us in a timely fashion, again in the first few weeks, we can give them a trial of steroids, i.e. oral steroids and nasal steroids, which can help improvement of these symptoms. However, if they present to us late, which is what happens in majority of the cases, we've lost the window of opportunity, or we've lost the golden period for treatment. There's not a lot available to reverse the condition related to smell, loss of sense of smell and taste. But the first thing I would advise the patients to do is to make sure that they've got a gas detector and a carbon monoxide detector fitted in their house, to make sure that if there's anything burning in their near vicinity, if they can't smell it, they can hear it for their self-protection and family's defense. The other thing which is available, we still give them a trial of steroid nasal sprays. We will do an MRI scan of the head to make sure the olfactory pathway and the pathway for hearing is intact. And then we would give them, for smell, we would give them what is known as an olfactory retraining kit, which is available from Amazon, and you can buy it. And people will then start to trial and stimulate their organ of smell to retrain it to so that they are able to hear, to smell various tastes. Smell recover, well, patients can recover to a certain degree, but it never goes back to where it used to be.
Well, yeah, we haven't found a way to do that yet. I mean, I've seen patients.
We can't reverse it.
You can't reverse it, yeah. You mentioned it can be any virus. What's the actual mechanism that causes it? You know, do we know that yet? What is it? What is it about COVID, I guess, specifically, or any virus, but in particular in COVID, that causes long-term loss? Is it damaging? What does it damage? Is it central, or is it?
It damages the neural receptors in the peripheral organ. So in the case of nose, it damages the olfactory nerves, which are naked nerves and nerve endings sitting in the roof of the nasal cavity and the side walls of the nasal cavity and part of the septum. It can damage that. And that's what leads to loss of sense of smell. And similarly, in hearing, it affects the nerves in the cochlea, or the organ of hearing, which leads to hearing loss.
And one of the big things with any infection, obviously, is a cough. But one thing in particular, I think, so a chronic cough. But a chronic cough is a major problem, a major symptom. So what tends to happen, you'll probably know, because I feel like ENT for a cough is almost like the dumping ground, because the person might go to respiratory, they get seen by the GP, they get seen by the chest physicians, they might think, was it a neurological cause behind it? And then eventually they get seen by ENT, right?
Yes.
So what kind of things, and to be fair, ENT come up with a lot of solutions, I find, because all these systems, fail to find a cause. ENT
is the last stop. And a lot of times we get patients with a cough who've been to the heart specialist, they've been to the respiratory specialist, some have been to a neurologist, and then eventually come to us and say, right, can you help us? And
please find a cause. Because and to be honest, a lot of time there is, but so not people, but what kind of stuff? Because honestly, ENT, because I don't know what, maybe because it's more procedural based, or I don't know what the reason is, but what are the kind of things that, when you get those kind of patients, what are the kind of things that could explain the chronic cough?
So the first thing that I want to make sure, and we want to exclude, are there are two things that we want to exclude from the ENT perspective, which can give rise to a cough. One is a chronic postnasal drip, and the second one is acid reflux. Acid reflux can lead to, again, basically what it does is acid reflux can cause the cough, and acid reflux can also exacerbate cough, because particularly at night when you lie down flat and the acid comes up to the back of the throat, it can lead to some degree of postnasal drip or increase in nasal secretions. And that leads to then coughing, and that can have an effect. But once that is excluded and that is not the cause, and everything else is completely normal, which is very common, and the patient is still coughing, then it becomes a very difficult dilemma to treat. And one thing I've come across is that these individuals will have what is called a hypersensitive respiratory tract. And these patients who have a hypersensitive respiratory tract, when you ask them one question, before all of this started, did you have a rather aggressive or a long-lasting cold? Majority of the patients will say, yes, it was a head cold which brought on my coughing.
And it never got better. The cough.
The cough, yeah. And it's again the change in the mechanism of the neural hypersensitivity or hyposensitivity, which leads to the coughing. And that's why it's known as the hypersensitive respiratory tract syndrome, where the patient coughs. The good news is that this cough usually settles in time. The bad news is, how long will it take to settle, and we don't have an answer. Some will settle within a few months, some will take a year or two. But the commonest thing that I advise my patients to do, so a cough which is because of a chest problem, you can't hold that cough back. It has to come out because it's you're blowing out phlegm or whatever. But a cough which is secondary to a hypersensitive respiratory tract, this cough, when you can actually, if you want to hold it for, suppress it for a few seconds, you can. And for these patients, I tell them to walk around with a bottle of ice cold water with crushed ice. And every time they have a desire, they want to cough, I tell them, look, the moment you're about to cough, if you can hold your cough for a few seconds, take a sip of ice cold water with crushed ice. And what it does is it breaks the cough reflex. And if you keep on doing it over and over again, it breaks that mechanism of neural hypersensitivity, and it allows a significant improvement in the coughing.
It's quite a good hack. I might steal that one for my patient. I don't know. So that's interesting. So, because it makes sense, you know, if they walk around with ice cold, you know, I've never recommended that for everyone, but I think
crushed ice with ice cold water.
Interesting. And it sounds like it'd be quite effective as well. Because I'm just thinking
quite
now,
effective. It's quite effective. And all these patients, majority of them will be walking around with a bottle of water because they want to sip on it, but because the throat feels dry. But what you tell them is, look, that water is fine, but go around with ice cold water with crushed ice. You're sitting in your house, you're reading a book, have that next to you. You're watching the telly, have it next to you. You're driving, have it with you. And every time you want to do that, just have a sip of that, and that will just break the habit of throat clearing, because, you know, what it does is it freezes. Momentarily, it freezes everything, and the sensory pathway is momentarily blocked and frozen. And that leads to an improvement of their symptoms.
One of the things you mentioned was, well, first, thank you for that, because I would definitely use that. But one thing you mentioned was a postnasal drip. So, obviously, from my understanding, a postnasal drip generally comes from some sort of sinusitis, right? So, whether it's acute or chronic, it builds up all sort of like the gunk and congestion that goes to the back of the throat when the person lays down. Obviously, you see the advanced cases; they don't get better. So, and do you see is the stuff you see, you know, from a chronic cough and the postnasal drip generally down to chronic sinusitis?
So, I think the most important thing is to identify and say first clarify what is postnasal drip. Postnasal drip is infected discharge dripping down the back of the nose. It usually will have a foul taste to it, and it can have a color to it. That is when you will call it that it is postnasal drip. Otherwise, our sinuses produce a few liters of mucus during the course of the day, and that is not postnasal drip, because that's just normal mucus which is dripping down. However, patients who are over the age of sometimes 60s, sometimes 70s, sometimes 80s, may come to you and say they have a lot of mucus dripping down the back of their nose, or they have a runny nose, which gets worse when they eat food. And that is a different condition, not to be mixed with postnasal drip. That is classified as senile rhinorrhea. Age-related runny nose, secondary to an imbalance in the autonomic nervous system.
That's interesting. So I didn't know. I've never heard of that actually. So that is obviously in older people.
Older people, yes.
And it happens all the time, or just when they lay down?
They'll say, I walk around with a handkerchief, or they'll say, whenever I'm having food, my nose starts to run.
Interesting. That's actually really interesting. And what can be done with that? Is it one of those things you can't do anything about?
You just can give them a trial of some nasal steroids. Usually it's something like Ranacort or something on those lines. And that doesn't work in everyone. It works in some individuals. But again, there's not a lot we can do about it. But the most important thing is to ensure that you have the correct diagnosis, and it stops the patient from believing that they have a condition which can be cured.
And what about people say they've got, because I get this a lot actually, people say I've got constant like throat clearing. Like,
yeah, throat clearing.
Yeah, like
again,
constantly.
it's a habit. And it's a habit. You need to exclude they have no infections in the sinuses, and you need to exclude that they do not have any symptoms of reflux of acid. So no heartburn, no indigestion, anything of that sort. Give them a trial of some Gaviscon for a few days to see if it helps them, couple of weeks. If it doesn't help them, the thing again that helps these patients is help them to break their habit of throat clearing. And once again, the ice cold water with crushed ice does wonders.
Wow, that seems like it's a good
It's
hack
a great help, and it actually works. I've had quite a few GPs who've read my letters and then come back and said, actually, we've started to do that to patients and we found it quite helpful. And it helps break them the habit of coughing and throat clearing.
And for someone who's got chronic sinusitis, so often what happens is while they wait, which is not the right thing to do in my opinion, they keep coming in with, acute on chronic attacks and get antibiotics and steroids while they're waiting to see ENT. So what do you essentially just wash it all out, under GA base? Is that what happens?
So first of all, the important thing is to ensure that you have the correct diagnosis of sinusitis or rhinosinusitis, because your nose and sinuses will be infected together. Somebody who's got a diagnosis, the diagnosis or the criteria for the diagnosis as mentioned in the literature is nasal blockage, nasal discharge, plus or minus symptoms of facial pressure or pain, plus or minus colored nasal discharge, okay? You can have, a lot of patients will just have facial pain without any associated symptoms of nasal blockage or nasal discharge or loss of sense of smell or sneezing fits, just facial pain. And a lot of times they're being diagnosed as sinus infections. That's not usually the correct diagnosis, because infections will develop in a form of a crescendo. So you'll have a period when it builds up, then it's at its worst, and then it eases off. And that cycle takes a few weeks. But if a patient says, today I'm better, tomorrow I'm unwell, day after tomorrow I'm better, then I'm unwell, that's most likely mid-facial neuralgia, like having a migraine across the face. But on the other hand, if you have an individual who gets a colored nasal discharge, every now and again, it gets better, then it gets worse, it gets better, then it gets worse. In those conditions, it's best to organize a CT scan of the sinuses to find out if the sinuses are clear or they have signs of chronic inflammation. The treatment for that will be nasal steroids, sprays, for at least 6 weeks. And if they do not, so 6 to 8 weeks, and if they don't show any resolution, then a CT scan of the sinuses is the way forward to confirm that suspicion. And then obviously, if they keep on getting recurring episodes, then they would need to see an ENT specialist for surgery.
Interesting. And there's one thing I'll touch on briefly, I think, is around sort of cancers and tumours. Now, I've been reading up a lot on this, and the numbers of, in particular, younger people, not ENT, but across, not just ENT, so across all the specialties, the number of young people getting diagnosed with cancers is rising faster than the other group. Why do you think that is? Is it just because we're getting better at diagnosing it, or do you think is it like a wider lifestyle thing potentially that could be causing all this?
I think there are both factors to play. So there are, for example, in ENT, because of our improved quality of investigation, we are picking up cancers a lot earlier. For example, thyroid cancers are picked up very early, things which would have never been picked up. So that is because our quality of diagnostic tools are now far better than what they were before. So that's one thing. But why people have it, or why the younger people are getting it, I think it's got a lot to do with our lifestyle. So it's the lifestyle means your eating habits and the kind of food that we eat. And there's a huge increase of the processed and ultra processed food which is available in the market. Along with that, the element of fast food and takeaways, that itself, we do not know about, they do lead to, they would affect one way or the other, they would affect how the body responds to it if you take it on a chronic basis. Simply along with that, you can see it's not only cancer, but obesity is on the rise as well. Again, a result of the kind of diet we eat. But along with that, there are other elements of active and passive radiation that we are exposed to in our surroundings on regular basis, which wasn't present in the years gone by, which can have an effect on how the cells repair themselves, and again, can lead to an increased chances of developing cancers.
One interesting thing, I didn't even have this, I didn't think of this until now, is, well, mobile phones. Now you need to, like,
I didn't want to say that I specifically didn't want to use that word. But there is literature available now, where it says that mobile phones can affect, directly and indirectly affect us. Now, directly because of the invisible element of the radiation, and directly because of the effect it has on us spending a lot more time on looking at mobile phones, which means it affects your sleep, which indirectly means if you have lack of sleep, it affects, because 8 to 10 hours of sleep is advisable. And the reason it's advisable is because as doctors, as scientists, we know very well that the body repairs itself when it is asleep. But if we are depriving the body of the needful sleep, then we are also depriving the body of the opportunity to repair itself. And similarly, fatigue has an effect which negatively affects the body to repair itself. Again, these are indirect effects or direct effects, whatever you want to call it, of the use of mobile phone or increased frequency and duration of use of mobile phones. Plus, it physically affects us because of the position of the head. Half the population is now there. And then people turn up with having problems with neck pains. Similarly, hearing with headphones, call it headphones or call it on the ear, it has an effect on hearing because it affects, people are developing hearing loss because of loud exposure of noise, as well as leading to tinnitus. So these are the effects where mobile phones actually can have directly or indirectly on the human body.
And you mentioned obviously a big part of that is around sleep. Do you deal much with sleep issues like insomnia? And again, it's one of those conditions that ENT
I do get a lot of patients with sleep apneas. Yeah, that's
as the cause of insomnia.
So snoring, sleep apnea, not insomnia as such. Insomnia will go more to the sleep physicians. But snoring and sleep apnea is what I deal with a lot.
Another thing that I think it kind of probably cross tapers a bit with neurology is, I think one of the most painful conditions is trigeminal neuralgia. Now, do you see many of those patients who, because they present this awful, right? So they present with pain and they normally get started on some kind of neuropathic painkiller, right? So gabapentin, amitriptyline, steroids, whatever it might be. But a lot of these patients just have this debilitating pain, and they're the ones that we tend to refer. But is there anything that can be done,
so
ENT-wise?
ENT-wise, we don't have a big role to play for trigeminal neuralgia, apart from some patients presenting to us with pain, severe intractable pain on the side of the face or around the ear. We essentially, once we have done all the investigations to exclude any other cause, so tumors, etc., so MRI scans, CT scans, they've all been done, then we would share those patients or refer them across to a neurologist. And generally, the neurologist will give them some medications which help reduce the acuity of certain nerves, certain types of painkillers which helps with neurogenic pains. And if those painkillers are not helpful, then we would refer them across to the pain specialists. And pain specialists then have a variety of treatments of blocking various levels of the nerves to help improve with the pain.
Interesting. Yeah, I think it's one of the most awful conditions. And, that's why I asked you, because I think it tends to be one of those things, again, when patients get past pillar to post, especially the ones that don't get better. I think a lot of them do get better, with medication.
They do.
But there are certain, then the ones that don't, though, are the ones that really suffer because it's really bad. And they're the ones that tend to go around the houses, say head and neck, different specialties within head and neck, neurology, and they're not even stuff like orthopedics, spinal surgery, all these places. And, but yeah, so it's good to see here there are some things that you can be done.
Pain specialist for chronic pain, I think the best thing would be to refer them to a pain specialist. If a pain specialist wants the help of a neurologist, or if he or she think that the patient may require the help of a spinal surgeon, they would do the needful. But if they feel that this is simple neurological pain and doesn't require any further input, I think they're the best port of call to treat these patients.
Now, just one last condition I want to just touch on, is around eustachian tube dysfunction as a cause for ear pain, ear symptoms. Now, you're giving that smile because you think, I know it's one of those conditions that's very hard to diagnose and treat. But yeah, can you talk a bit about it?
Right, okay. So this is a condition that again, being an ENT surgeon, we see it quite regularly. Eustachian tube dysfunction is a very difficult diagnosis. It's not a straightforward, easy diagnosis. However, we have diagnostic tests in the clinic, such as pressure tests, etc., which will help us diagnose in that direction. There's also a questionnaire available now called the Eustachian Tube Dysfunction Questionnaire 7, EDTQ7, in the literature, where you can fill out, and if the score is higher than a certain point, then it is suggestive that the patient has got one-sided or both-sided eustachian tube dysfunction. And essentially, if I mark it very simply, these are the individuals who will find it very difficult to equalize the pressure in their ears when they try to pop their noses. That's the simplest way I can explain or describe it.
One thing patients have said this to me actually, that it's worked, is that if they get like a balloon, it's like a small device.
Yeah, it's called an autovent nasal balloon.
That's it, autovent, yeah. And basically they pump up the balloon, they hold one nostril and then they blow up a balloon with their nostril and then let the air go back into their sinuses.
Correct.
And there is pop and they
Correct.
It's wonderful. But you can't do that long term, surely. That must be quite risky.
No, it's not actually.
Oh, okay.
So it's helpful because what it does is it helps strengthen the muscles around the eustachian tube orifice. So it's actually helpful and eases out symptoms in a lot of cases. It's again available over the counter, doesn't require a prescription. It's quite helpful. But for patients who have eustachian tube dysfunction, which is present for a long period of time, diagnostic, we actually now have a treatment called a eustachian tube balloon dilatation, which is available to help improve the functioning of the eustachian tube.
Interesting. Okay. I just want to touch on that. I know I don't want to go too much into it because I know it can be a bit of a rabbit hole. You could talk hours about it without coming to anything useful. But yeah, just so what a doctor, I do this for everyone, but what Mr. Asad Qayyum's top 3 tips for healthy ENT, so his hearing, swallowing, good sleep, what are your top 3 tips? I think I know what you're going to say as an ENT surgeon, but I want you to see what you say.
So from the ears perspective, I would advise patients to avoid exposure to loud noises because you may not be affected by it today, but 10 or 15 or 20 years down the road is when the cochlear degeneration will start, much earlier for yourself than your peers. So avoiding loud noises is one thing I would strongly advise. With reference to the noses, I would advise you that if you are an individual who may have some symptoms of allergy or concerns, one thing which is very helpful is to use a salt water wash available over the counter with various formats in a neti pot or whatever in other formats, and you can get that to flush your nose. That actually helps keep the industrial pollutants, which are quite common in today's day and age, away from the nose and keeps the nose clean. And this is more important for individuals who are involved in physical manual labor. So people who work on building sites or in suit or coal, etc., where the nose can be affected. So it's a good way to keep these pollutants away, which in the long run can have a harmful effect to the nose and the nasal lining. With reference to the swallowing and the throat side of the thing, I would advise you that if you ever develop symptoms of regular throat clearing or coughing, try having ice cold water with crushed ice to break this habit of throat clearing and coughing. And with reference to individuals who are have a hoarseness of voice or are singers, it will be advisable that before you start singing, warm up, cool down, and have plenty of fluids to ensure that your vocal cords are well lubricated. And finally and lastly, please make sure you have good, restful 8 hours of sleep, because that helps on all facets of your health.
Ms. Asad Qayyum, thank you so much for today.
Thank you very much for having me.